as to our 19th Annual Social Justice Conference. Dr. Nazmi is the Cal Poly Presidential Faculty Fellow for COVID-19 Response and Preparedness, and today he'll discuss public health equity issues in the context of COVID-19. So please join me in welcoming him.
Thank you, Claire. Welcome, everybody. I'm really happy to be here. And like Claire mentioned, my name is Aydin Nazmi. I am a professor in the Department of Food Science and Nutrition in my regular life. And I'm also an epidemiologist. And so I have been kind of conscripted here in the role of faculty fellow for our COVID issues, right? So I've been working very closely with the university, also local jurisdictions and public agencies, and it's been a year now, as we all know. The aim of today is really to give you a scoping review of COVID-19 and public health equity. So I'm a social epidemiologist by training, and that means I look at disease patterns in human populations, and I look to examine and address social factors that impact health outcomes, right? So we know that there are many variables that impact health. And in my world, what I focus on are the non-biological, right? So I focus on typically things like education, income, disparities, and this thing that we call equity. So one of the first things that I'm going to do is take you through a couple of definitions. So I'm going to share my screen right here. Let me start by throwing up my title slide. You all can see that, I reckon. And so I want to throw out a caveat, and I hate to start with a caveat, but the problem when you talk about public health is that it is a massive, massive topic, as we all know. And similarly, equity is a massive, massive topic. So I am going to today, in 45 minutes or so, I do want to leave some time for Q&A. There's a lot to think about. So I'm going to take you through kind of surface level, high level, let's say, high level issues associated with COVID-19 and public health equity. And we are asking the question, is this the same old story? What do I mean by that? We'll get there in 1 second. So let's just start off. Here's my overview. And the overview is beginning with defining public health equity. How do we study it? What do we know about it? And then what is the COVID-19 public health equity story in the United States? And finally, getting to the question of, well, is this the same old story? So let's begin with posing the question of what is public health equity? By the way, if you have questions, jot them down. And at the end, we will have time for a Q&A. I find that in talks like this, with these kind of complicated, contentious topics, usually the discussion is when I learn the most, and I think there will be plenty of things to talk about. So, public health, also called population health. Epidemiology is the science of public health. So, in the world of public health, we look at groups, right? The public, the populations. However you want to categorize that, whether they're small or whether they're massive, like at the country level or global for that matter. And we aim to improve population health for all, right? That is right from the outset, the goal of public health. And it follows that by nature, public health is social, right? It is 100% about how humans live in their societies, how we organize our societies. By nature, public health is collectivist. Collectivist meaning the goal is the good health of the collective, of all of us, right? By nature, it is altruistic, seeking good for others. And as such, the proposal of public health is also therefore justice seeking, right? So, in that we are explicitly bringing up those who are down, right? And as a result, like it or not, the world of public health, the study of public health, certainly the application of public health is political, is quite political. This takes us into the realm of the powers that organize and legislate our societies, our bodies, our environments, our labor, our money, and even our relationships. Okay, so I am always very upfront with public health is political. If somebody's trying to study public health in a vacuum outside of the realm of politics, then it's going to have repercussions on the applicability of what you're doing, because all of the major legislative decisions, all of the policies associated with the outcome of health happen in the halls of the people who make decisions. Now, whether that's at the school board, whether that's at the city council, whether it's at the state or federal level, politics is an inherent part of public health, right? Now let's look at this equity terminology, right? So just to differentiate a couple of things here. On the far left, I have inequality. In the middle, I have inequity. Let's look at those two. And let's see, I'm not sure if you can see my cursor here, but if you can, I'm circling inequality. So inequality is, by definition, imbalanced conditions, right? And so is inequity. So in that definition, they're similar. Inequality and inequity also suggest that there are differences, right? For example, in access to resources, opportunities, etc., between groups of people. The difference here that I want to point out is that inequality, technically speaking, is what I call agnostic. It is unequal, right? It's kind of a mathematical approach. This does not equal this. They are disparate, right? They're unequal. There's inequality. Fine. Inequity is a little bit more of a nuanced definition, and in the world of public health, we talk about inequity a lot. In the world of social justice, we talk about inequity a lot. And inequity is not agnostic. In other words, there is a judgment, and the judgment is this is not fair, right? This is unjust, and that's why when we talk about public health and we throw around words like unequal, sometimes we like to get a little bit more nuanced, a little bit more precise and say, yes, they're unequal, but let's make a judgment call on that. That is not fair, right? And what we want is to generate equity, right? So the question is, what is fair? Yikes, I have a 6-year-old and we talk about this all the time. What is fair? And, surprisingly enough, kids have supremely developed notions of what is fair, unlike adults. So is fair treating everyone the same, or is it fair to treat them differently based on their needs, right? And I don't have an answer for you, but this is what I want to kind of prime the conversation with. What is fair, right? I'm going to show you a graphic that you've probably seen before. And this is old. It's been around for a long time. On the left, you have equality. On the right, you have equity, just like I had. And you have a group of 3 people watching a baseball game, and there is a fence impeding the view of the little guy there. And the one in the middle can see just over the fence, and the one on the far left can see over the fence and then some. And what you see here is equality in the distribution of these crates to these guys. And that means they are all treated the same, right? Agnostic. Everybody gets the same thing, independent of where you are, independent of what your needs are. Equity, on the other hand, would redistribute these resources such that the end point, in other words, look at their head level, right? The end point then is the goal, and the goal is to achieve equity. And by putting that as a priori goal, what you do is you give people what they need in order to become equal with everybody else. So the concept of justice here says, well, this tall guy can already see over the fence. He does not need a crate. The middle guy does need 1 crate, and the little guy needs 2 crates. So we have treated these people unequally, right? We have not treated them the same. Is that still fair, or is the equality approach more fair? In the world of public health, we confront this all the time, right? And I just want you to put this in the back of your head as different types of approaches. I focus on equity today. I focus on equity in my work and in my application of public health. And in the world of public health, typically this is what we do, because instead of putting the folks who are already on top of seeing over the gate, further over the gate, right? We try to bring up the folks who need it the most. Now, sometimes there are two other sides attached to this graphic, and on the far left is the sad truth of reality, where the top, let's just call him the top 1% for now, is flush with crates, and of course you have some of the population that's barely seeing over, and then some of the population that is buried in a hole here. And then on the far right, this is removal of the barriers that was not allowing some of them access, right? Sometimes in this, I've seen this labeled liberation, I've seen this labeled justice. Now, there are caveats to what we're looking at here, but this gives you a kind of a very surface level interpretation of these concepts, right? So according to the CDC, public health equity, and I'm just going to read this, public health equity, or health equity, my apologies, is achieved when every person has the opportunity, key word there, to attain his or her full potential, and no one is disadvantaged from achieving because of social position, right? This is something we come back to a lot in the world of public health and equity, social position or other socially determined circumstances. Health disparities or inequities, and notice that the CDC actually puts these two terms almost as synonyms. I might argue with that, where disparities is a little bit more like inequalities, agnostic, whereas inequities, like we talked about, have a judgment call associated with them. Health disparities or inequities are types of unfair health differences, there we go, closely linked with social, economic, or environmental disadvantage that adversely affect groups of people. Now, let's operationalize that, right? So if we're operationalizing that in this world, typically we refer to the so-called social determinants of health. And we have, I don't expect you to read all this, but I do want you to get an idea that at the bottom, this is health outcomes, right? All of these things that are associated with health are somewhat determined, partially determined by all of these things. And this is just a partial list, mind you. Think of this as like the tip of the iceberg. And most of these are social determinants: economic stability, neighborhood and physical environment, education, food, community and social context. And what we normally think about, I have to say, this is a very practical guide, mind you, for social determinants of health. And you know, what we normally think about, especially in the United States, when we talk about health, what's the first thing that pops into your mind? Boom, healthcare. We talk about doctors, we talk about nurses, we talk about health insurance, right? Because that's the way we have organized our system. And the fact is, the more powerful and the more number of variables in the social determinants of health category suggest that really that's where we should be focusing on when we talk about health. So what do we talk about when we talk about health? Typically, we go directly to healthcare. You guys, healthcare at the end of the day is where you go once you get sick, right? From birth, right? Intergenerationally, throughout the course of life, we have all of these social determinants of health that may not be quote unquote health variables. Employment is not a health variable, but I think we can all very explicitly agree that employment, things like income, safety, higher education, hunger, these things directly impact health outcomes. So we think about the social determinants of health and disparities, inequities, inequalities, differences between groups in social determinants of health, and we look at those as root causes, sometimes called the causes of health outcomes, right? So I want you to think very broadly about health, including all of these social determinants, and not jumping directly to health care that we kind of have a tendency to do, at least in the US context, certainly. Why should we care? I propose that health is a common good. I propose, not just me, mind you, health is a human right. Well, at least it should be, certainly in 21st century America. There is a UN Charter on human rights, and health is at the top of the list for obvious reasons, because the alternative is what? That healthcare, that health is a privilege, which means that some are entitled to it, some are not. Health is clearly a human right. And furthermore, if you need more evidence, healthy humans, and we see this in the context of COVID very clearly, healthy humans keep other humans healthy. If my neighbor is sicker, I am prone to be sicker. If my neighbor is healthier, I am prone to be healthier. It is in my best interest to have my community members healthy. And of course, healthy humans contribute to society better, right? Healthy humans contribute to society better. And if you want to put this in the language of, well, legislators, shall we? Not to be, not to go down this path, but healthy humans save countries money, right? And we see this time and time again, and there's a lot of evidence to support the proposal that healthier populations actually do much better in terms of GDP, in terms of productivity, in terms of healthcare expenses, and so on. Why should we care? Because health is a common good. I want to digress for one moment. This is what you get when you ask a professor to come speak. I want to digress about the roots of inequity, the roots of public health inequity in our case. And this is philosophical, historical discussion that we can't get into at this moment. What are the roots of inequity? We know this exists. We know these have existed in human societies since time immemorial. Where is all this stuff coming from? Well, let's just talk about the context of the United States. Certainly, the roots of inequity come from, in addition to other things, deep, ongoing, and troubling, I might add, colonialism, right? The decimation of indigenous communities, colonial mindset, racism. This is systemic, institutional, social, individual level. Classism, this is the differences in availability and access to goods and services to some, but not all. Sexism, heterosexism, and we see this, and we have seen this in all human societies, that there is big differences in terms of gender and gender identification, ableism, and of course, I will propose capitalism that exploits labor forces, commodifies things like health, commodifies things like human rights, other nasty isms, shall we say, as causes, as the roots of public health inequity. So right away, we see that this is all very complex. So how do we study it, right? How do we study public health inequity? I'm going to give you a very simplified example, and I'm going to maybe do a little bit of a spoiler alert and talk about COVID-19, right? How do we study public health equity? I will take you through the very general steps, and you scientists out there, you students out there, will recognize the process I'm about to outline as the scientific process, right? Because at the end of the day, public health is a scientific pursuit. And it is a complex one. It is social science. It is biological science. It is medical science. It is a multitude of different sciences coming together. So we observe a population health characteristic, and let's call that COVID-19. And be more specific, let's call it COVID-19 mortality in the United States. And typically in our world of public health, we put some sort of denominator on it so that it's the proportion is there, right? So COVID-19 mortality in the United States per 100,000 people. And then we say, okay, we've got this thing that we want to study. Let's identify some descriptive variables, and let's just pick one out of many and call it race and ethnicity. And we know, our hypothesis is, because we know these racial and ethnic inequities exist, we will expect there to be differences in COVID-19 mortality as well. But then we have to get the data, right? So show me the data. We analyze the data. And here's what the data for the United States shows, that COVID-19 mortality in the United States per 100,000 people among white populations is 120. So 120 per 100,000 people of those who have COVID die from it. Among Black populations, it's 155. Right? And among indigenous populations, it is 211, right? So almost double that of white populations. So what is our conclusion then? Well, our conclusion is there's 1/3 higher mortality among Black compared to white populations, nearly double for indigenous versus white populations. So we go from the conclusion to then what? What do we do about it? Well, we determine and we try to address the causal factors. This is a problem, you guys. This is what keeps me up at night. How do you address hundreds of years of genocide, social oppression, economic disenfranchisement that has led to these predictable, I use predictable very intentionally here, because this is a predictable outcome, right? If you were to do this from scratch and say, I'm going to give one group of people this treatment in this environment, another group this treatment in this environment, what will the health outcomes be? All of you guys could predict what would happen, right? So all of this that has led to these predictable and significant health disparities and injustices. This is what keeps me up at night. This is what I want you all to think about as we move forward and talk about things like causality in public health and public health equity. How do you address the roots of inequity, right? Where do you start with a list like that complex? Where do you start? Now, this is a 1 hour talk, right? I'm going to talk for maybe 35, 40 more minutes, but we're not going to solve public health equity. I hate to break it to you. However, at the end of this hour, I hope you will have an idea of how to approach the issues given the evidence that I'm going to show you. Okay? This will be a primer. What do we know? So my intention here is to walk you through a few ideas that will hopefully compel you to think more or to think more deeply about public health equity. We're going to revisit this at the end of today's conversation, but let's start with what we know and what we've been knowing for a long time, right? Historical evidence is very clear, and we're talking about before public health equity was even a thing, right? At the outset of the pandemic, you know, a year ago, 11 months ago, do you remember? We saw lots of news outlets reporting, oh, coronavirus exacerbates health disparities, as if this was news to us. And, you know, don't take me wrong, I'm happy that stuff like that is in the news because it brings it to light. And I think coronavirus, the pandemic, has shed light on the impact of these disparities. That is wonderful, but we've known this. Hippocrates, 400 BCE, looked at the differences and described the differences between populations based on the environment, the air and the water and the food and other habits that different groups of people were exposed to. In the early 1800s to mid 1800s, when this type of academic kind of public health pursuit really started taking shape, we have folks in France, England, Germany, all of them describing things like excess mortality among poor populations, things like early life poverty affecting health, things like poor social conditions, working conditions affecting health, things going back to Hippocrates, again, soil, air, water as major causes of disease among poor populations. So this is not new. This is historically relevant, valid, and validated. We've got data and writings to that effect. Contemporary evidence, I'm going to give you a couple of examples in that to show you the significant and persistent inequities. In just 4 examples I'm going to throw out here very quickly. We have a whole litany. We have generations of research. We have thousands of academic papers on this. I'm going to give you a couple: maternal outcomes, infectious disease, chronic disease, and lifespan, just to give you an idea how significant these inequities are in this broad range of outcomes, right? So starting with maternal outcomes, you see here, so I'm going to walk you through this. This is maternal outcomes, and I'm bringing out the variables of race and ethnicity. Okay, just to contextualize a little bit, the United States is tied for 56th place. Yes, 56th, not 5.6. 56th place globally with an average death of 19 deaths per 100K. That's pregnancy-related deaths of the mother, okay? Maternal mortality. So we're really doing quite poorly in just as a side conversation on the public health, global public health stage. But let's look at within the United States, white women per 100,000 live births experience 13 deaths per 100,000 live births, right? Our country average is 19, and that's what I mentioned was number 56. If you look at American Indian, Alaska Native women populations, it is, well, it's 2.5 times higher at 30 per 100,000, and among Black women, it's even higher at 41 per 100,000 maternal outcomes, right? Now, Look at infectious disease. Infectious disease, same thing. Same thing in terms of the inequities experienced by partial parts of the population. This is by race, race, ethnicity, and gender. So this is diagnoses of HIV infection from about 5 years ago. On the x-axis here, we have number of infections. On the y, we have characteristics of populations. So if you look at Black MSM, men who have sex with men, white MSM, Hispanic, Latino, and then you have Black women through heterosexual contact, Black men, heterosexual contact, Hispanic, Latino women, heterosexual contact, and white women. Now, obviously, very quickly, you can see that there are a number of different inequities here, a number of different things, characteristics that are unequal. And you see that between heterosexual and homosexual groups. You see that between men and women. You see that between the different race and ethnic groups among all of those. So here we have a litany. We have a complex kind of array of all kinds of inequities, inequalities in outcome happening here in the context of infectious disease. And this is not just HIV. If you study any sort of foodborne outbreaks, right? Flu, all of them have very similar patterns. Now let's look at chronic disease. So this is heart disease death rates, pretty recent data from the CDC. This is heart disease death rates in adults. And this is inequity by place, right? And so you guys have heard by now that your zip code determines your lifespan. This is actually quite true. And if you look at the key here, the lighter red is less heart disease rate, and the darker red is more heart disease rate. So just right off the bat, you don't even have to know the numbers. Look at the colors. Where is the worst heart disease death rate? Right here in the middle, right? In the kind of post-industrial age, this area of the United States has become known as the Rust Belt. And in the world of chronic disease and epidemiology, it has also been called the heart disease belt. What do they call it? The hypertension belt, right? So this is basically a real clear and persistent, I might add, it's been like this over time, differences in the proportion of people affected, right? And so if you overlay this with all of the other inequities, you can see that we do indeed have a very complex story to tell here. I'm going to show you the last one, lifespan by income and by gender. So on the x-axis here, you have household income percentile, right? So from poorer to richer, think of it that way. And on the y-axis, you have life expectancy. So right away, you see the disparity between men and women. Who lives longer? Women. But it also depends on gender. On household income percentile. So you will see that all the way until about the 70th percentile, you have a pretty significant gap, and some of those gaps widen at different proportions, and they come to be a little bit narrower here towards the end. So there's a couple of different stories here. Number one, poor folks, men and women, live less than rich folks, right? Very basic and very clear here. What if we quantify that, you'll see how shocking it really is, because the difference between the poorest and the richest men is something between, about 75 years old for the poorest, and something, I have it written down here, about 83 years old for men. For women, it's 80 and 86, right? So you have life expectancy gaps of 6 years, 7 years, 8 years, and that is apparent for a number of outcomes, not just lifespan. And those examples I wanted to give you as a grounding. Now, what the heck is going on? We have to ask why. Why are these things happening? So is it that race and ethnicity and gender and identity in place cause poor health, right? Do I have poor health because I have dark skin? Do I have poor health because I have not that much money in my pocket? What is the issue of causality here? Let me pose another question. In order to get the answer to that, ask yourself, what are the forces that drive health, right? And I want to give you some examples of these forces, because we know race per se, ethnicity per se, gender per se does not mean you have worse health, right? But there are forces based on your identity that do impact health outcomes. And I want to talk about some of the key ones right here. Here is a force. These are the forces that drive health. Educational opportunity, right? So here we have some data from Brookings. On the left, you have US school enrollment, 18 to 24-year-olds, largely the college age population. And let's just stick with this one for a second. If you look at white, Black, Latino, and Asian groups, you will see, you can't see the key very well here, but the dark blue is in school and the light blue is not in school. So educational opportunity. Who is in school? Well, some groups are in school more than other groups. There's your basis. There's your force for outcomes associated with educational opportunity. On the right side, we have educational attainment, right? So outcomes of roughly college-aged folks, and a total of something about 36% less than high school, 38% some college or associate's degree, 25% of folks in this country, in this age group, have a bachelor's or above. But look at that top, 25%, 31% for white populations, 14% for Black populations, 11% for Latino populations, 50% for Asian populations. A force, educational opportunity, that clearly can lead and contribute to inequities in health. Here's another force, the school environment, right? Racial disparities in school discipline. This is a relatively new but very interesting field of research that shows that Black students are 3 or 4 times more likely than their white peers to be expelled or face multiple suspensions. So if you look at the risk of being expelled, it's 3 to 1, risk of facing multiple suspensions, 4 to 1 from a very early environment. In school, we see that the school environment force can have obviously lasting and lifelong effects, not only on further educational attainment, but also in health outcomes. Here's another force, pay disparity, right? So unequal pay. If we look at folks with bachelor's degree or higher, middle skills, and high school diploma or less, what you see is even within these groups, you see a very clear line here, such that in the blue, white populations, independent of their education level, are making several $1,000s up to $10,000 higher than African-American and Hispanic populations, even though you have the breakdown by different groups. So even if you look at high school diploma or less, you'll see that white populations are making about 12% higher income compared to Hispanic and Black populations. Pay disparity, does that have a force on your health? Of course it does. Let me give you another force, politics. We've talked about this, and we'll continue to talk about this because, and this is one recent kind of topical example. We have legal marijuana use, right? On the right, imagine this is the US map, and legal marijuana use, the darker color is more, let's say, liberal marijuana use law. So the darker is recreational medicinal use. The green is medicinal use, and the lighter colors are either CBD or there are no laws at all. And then on the left, you have the control of the state legislature, and then you got the blue, Democratic, red, Republican, and then you have the purple split. And if you overlay these on top of each other, it is very clear, almost inevitable, that certain political affiliations, certain states with control of legislatures, Democratic or Republican, will have certain outcomes in terms of legal marijuana use, which is clearly associated with a whole slew of health-related outcomes, because when we're talking about legal marijuana use, we're also looking at justice system and penal codes associated with breaking those laws, right? Here's one last one I want to show you, home ownership. The gap between Black and white home ownership has widened since 1900, right? So to the people you talk to who say, we've got a long way to go, we're doing better, I would have to say, we're doing better on what, right? Let's look at the evidence. And the evidence for home ownership, at least, if you compare it with the green, Asian, blue, Black, purple, Hispanic, and the dark blue, white, you will see that from early 1900s until today, which is about 71% home ownership for white populations, it decreases pretty precipitously, right? By about, what is that? 12, 13 percentage points for the next group, which is Asian populations, and all the way down to 41 to 40, 45, 46%. So almost half, right? A little bit less than, a little bit more than half home ownership. And not only is this gross inequity, but if you follow it over time, you will see that, as the title says, the gap has widened between Black and white. So 71.3% and 41%. So there's a 30 percentage point difference. If you compare it in 1900, you'll see that it was actually less, right? So it was about a 27 percentage point difference. All of these are really relevant to the context of equity, because these are the forces that drive health, right? One thing to keep in mind here, you see these trends over time. They dip and they go up and they go down based on a number of things, whether it's social, economic, political forces. But the thing I want you to keep in mind is they change. They can change. We can make them change, right? Either through implementation of policy, economic, social policy, and otherwise. It follows that we can change the forces that drive health and that drive health equity and inequity. So let me sum up this section here. Public health is concerned with ensuring good health for all, right? Basic tenet of public health. Inequity is a problem, but as we just saw, it is addressable. It is controllable. It moves. We can move it, right? It is not inevitable. So the forces that drive health are many, and they include social, economic, and political factors, like we have seen. And I think the underscore here, what we need to keep in mind, is that it is adjustable. Okay. Now, it's been like this forever. This is the same old story. Okay, this is the same old story. Now, my question is, what about in the context of COVID-19? Is this also the same old story, right? So let's look at key similarities between what I just showed you with the same old story and COVID-19. Let's start with age. Now, age is a little bit fraught because there are a lot of biological factors associated with aging. But let's look at the disparities here. So this is a little bit confusing. Let's just focus on the far left here. So on the far left, the axis is age categories, okay? So less than 5 years old, 5 to 17, and so on down to 80 plus. This is percentage of the population, right? So in the dark blue, the percentage of the population that's less than 5 years old is about 6. The percentage of the population that's 5 to 17 is about 17%. About a quarter of the entire population is 18 to 34, and so on and so on. Okay. Now, the percent of cases of COVID-19 you will see are roughly in line, at least the curve is roughly similar, such that the proportion of cases is not too dissimilar to the proportion of the population. Yeah, you have a little discrepancy here, 17% versus 7%. 24% versus 35%, but the curve is roughly equal. Now, if you go all the way to the right, the proportion of deaths associated with COVID-19 in the same age groups, you'll see that they are absolutely not similar, whereby you have very low numbers, below 10% really, until you get to about the 70-year-old age group. And then all of a sudden, you have something like 60+%, 65% of the deaths associated with COVID in the 70 plus age category. Big disparity in age. Let's look at age and race and ethnicity, right? So break it down even further, and you'll see the same thing that you saw here. So on the y-axis here, we have death rates per 100,000. X-axis is age groups. These are just adults now. And you have the different, 3 different racial and ethnic groups we're comparing: white, black, and Hispanic, Latino populations. So in the very young category, 35 to 44 years old, you can't really see it. The black and Hispanic populations do have higher rates of death, but overall they're very low. As soon as you get to 45, certainly when you get to 55 and 65, the black and Latino bars just take off, right? And by the time you get to 75, 85, you see massive disparities such that, yes, everybody's risk for death increases with COVID infection as you age, but that increase is disproportionately borne by Black and Hispanic populations, namely Black populations, such that by the time you're talking about the oldest age group, you have something like a 900 deaths per 100,000 in Black populations compared to half that, less than half that, 420 roughly deaths per 100,000, right? So these are not clean lines always. It's not just an age, just a race, just a socioeconomic disparity. All of these overlap with each other such that they compound, right? Here's gender and work. Now, this is really important because we know that during the pandemic, a lot of jobs have closed. A lot of businesses have closed or have been restricted or have been closed for certain periods of time. And this is really interesting data showing that the pandemic has had a disproportionate impact on female employment, and this is employment in California, so relevant to all of us here. On the y-axis, we have percentage of workers, and this is percentage of workers time over, in the x-axis, time, right? So December through September. And you see the female lines are orange and the male lines are green. And this is a disproportionate impact on women. Can you see that? I mean, just if you look at it, you'll see that the dotted line here, and this is females that are unemployed, underemployed, or discouraged from working. And then the solid line is unemployed. You'll see that those numbers have shot up since the beginning of the pandemic, which was roughly February, March 2020. That has come down a little bit, but you'll see that it has outpaced the men. In other words, the gap is pretty significant, whereas in December, the gap was small or non-existent in the case of unemployment, right? So a disproportionate negative impact on unemployment among women. Women have fared worse, and this is true in almost all fields. Now, if you put mental health and gender on top of the kids equation, I have young kids, I can attest to how crazy they can drive you. But this from the Kaiser Family Foundation, which by the way, does a lot of really good public health work, shows the widening gender gap in share reporting negative mental health impacts from coronavirus. So if you look at women on the left, men on the right, and this is March 11th, the green is March 11th to 15th, and March 25th to 30th. So this is just a few weeks after. This is right around the time when the first kind of lockdowns were happening. And this is percent who say worry or stress related to the pandemic has had a negative impact on their mental health. So you see that women and men in early March, it's 36%. Women said, I have a lot of stress associated with the pandemic, and men said about 27% of men, whereas that jumped to 53% among women disproportionately, in other words, more so than in men who were at 37%. So both men and women indicated that they have more worry and stress related to the pandemic, but women disproportionately so. And you see that even stronger among parents, right? So men and women who are parents, you see a very similar pattern in women, and you see a little bit of a dissimilar pattern in men whereby that didn't increase much. So mental health status, we know, has also taken a significant hit. And mental health status, if that's not a force that drives physical health, I don't know what is. And of course, with place, this is New York, it's New York City. And on the left in the blue, you have proportion of positive tests per total tests, right? So the lighter blue is lower proportion of positive tests, so lower COVID, and the darker blue is higher proportion. So you see what parts of New York City were more affected than others. And if you overlay that with the proportion of the population that is white, you will see almost an exact inverse, right? So if you look at this area here, right, this is parts of Brooklyn, for example, very high positivity rates. And you see the proportion white, lighter is fewer white population in those neighborhoods, and you see light color. In other words, more people of color in this region, right? So those are some of the similarities. Those are the same or very similar patterns that I described with the other health outcomes. Let's look at some key important differences. One very important one is that COVID has been very acute very traumatic, like a car wreck. You're going 80 miles down the road and all of a sudden into a large oak tree. That is the acute and impactful result that the pandemic has had. So for let's see, I think a couple of weeks in late December, so right around here, COVID was actually the #1 cause of death in the United States. I mean, and look where we came from, right? From nowhere to #1 cause of death, exceeding the deaths from heart cancer. Now, this is we've in the U.S. If you've not been paying attention to the statistics, we have recently surpassed 500,000 deaths in the United States. Globally, it's about 2.5 million people, and in the United States, we've had about 30 million cases, right? And so, not only do you have an acute and impactful event here, but you also have the same or similar gaps. For the first time in many generations, life expectancy has actually gone down. It has gone down for white populations by 1 year. It has gone down double by 2 years, which is not insignificant among Black populations. Estimated life expectancy of all of us has gone down, and as you might expect, disproportionately so for people of color. Vaccines are here. Is there a light at the end of the tunnel? Who are the vaccines here for? Well, they're meant for everybody. Testing is free. Vaccination is free. What's the problem, right? Isn't that what you want? You socialists? Well, let's look at that. This is data from a few states. So the states that have the highest proportion of Hispanic populations, right, as a share of COVID vaccinations, cases, and deaths. So there's a lot here. I'm going to take you through just the top two, which is Texas and California. You look at all the way here at the end, percent of the total population that is Hispanic is about 40% in California and in Texas, right? And in California and Texas, they are actually the majority of the population. Okay, so question whenever somebody uses the word minority, right? We like to use minoritized as a more accurate depiction of what's going on in society. So 40% of the total population is Hispanic, but if you look at the percentage of deaths, it's actually 46 or 47%. So an outsized, disproportionate impact on the proportion of deaths, and certainly in California, an outsized percent of the cases. And now let's look at vaccinations, because in the world of equity, we want to make sure those at highest risk, Hispanic populations in Texas and California, for example, get the vaccinations first. They are at highest risk. That is the equity approach. What is happening? Opposite, right? So in California, Hispanic folks are 40% of the population. They are less than half of the percentage of vaccinations. Similar story in Texas, similar story with all groups, people of color. And you can go here to the, I don't know if I have a link here, but I can share that with you. Similar across all states among Black and Hispanic populations. So who are the vaccines for? I ask you again. Now look at this. This is data from a bunch of different states, ranging from the states who have a higher proportion of state residents who are Black to lower, right? So from Mississippi, which is roughly 38% Black, to Vermont, that is about 3-4% Black. Now, the line indicates the difference between the share of vaccinated folks who are Black. So in Mississippi, about 15% of the folks who have been vaccinated in that state are Black. However, they comprise almost 40% of the population. And again, you see these large gaps in almost every context. When you get down to Oregon, it seems a little bit better, but if you blew that scale up, you would see that there is still a significant disparity between proportion vaccinated who are Black and proportion of residents who are Black. So I ask you again, who are the vaccines for? The wealthy are taking an outsized share of vaccines meant for poorer neighborhoods. You see headlines like this all the time now, because first we were fighting over tests. Now we're humans, so let's keep fighting, this time over vaccines. And what you see is things like place-based privilege. So this is New York again. New York just has really good data. From lighter to darker, this is percentage of per capita by zip code of COVID deaths. And again, you'll see an inverse association here. The places, the zip codes that were most affected by COVID deaths have now been least vaccinated, okay? So this is place-based privilege or place-based inequity. You see the same thing in DC. Hardest hit, least vaccinated. You see the same thing in, this is Southern California. Hardest hit, least vaccinated. We're doing exactly the opposite of equity here. So the broader impact, I want to talk about this very quickly. Hope we'll have time for questions. The broader impact of the COVID pandemic, the problem here is this is not just going to be the, okay, we got vaccinations, we got herd immunity, let's just put this whole thing behind us. Well, if you look from April to June, you will see that the national average compared to Black and Latino populations in terms of expected employment income loss by race and ethnicity. So this is share of adults in household where at least one person expects to lose employment or lose employment income in the next 4 weeks. You will see that the national average hovers around 30 to 35, 36%, whereas in Black and Latino populations, it is much higher and has maintained a much higher proportion over this period. So this suggests that employment down, employment income down, disproportionately impacting Black and Latino populations. You see something very similar here, substantial economic hardship among Black and Latino populations, unable to pay for basic necessities, used up most of the savings, took out a loan, suffered economic consequences, suffered any economic consequences, 21% among white populations, and 55% among Black and Latino populations. So the problem with equity is that when you begin with a place of inequity, when there's a shock, whether it's economic, whether it's social, whether it's disease, pandemic in this state, the inequity only gets worse. We widen gaps, okay? Relevant to some of you college students out there, canceling all community college plans. Community college has taken a real hit over the pandemic. And we see that low income versus high income folks, 15% versus almost 45, 46% are canceling college. So if you're low income, if you're Black, Hispanic, or a person of color, you are more likely to cancel your educational plans because of the pandemic. So I come back to, is this the same old story? Well, kind of. Many of the attributes of longstanding public health inequities manifest here. Expected disparities. We know that there are disparities in outcome by age, gender, race, ethnicity, neighborhood, and so on. We know that there are disparities in access in the case of COVID to testing, to care, to vaccines. And I put an asterisk there because this is supposed to be free in the context of COVID, at least testing and vaccines. And even still, we have an outsized, a disproportionate impact on folks who are already hurting. A couple of novel or acute factors that differentiate this pandemic, make it worse, make this inequity worse. Massive and disproportionate death toll, not to mention the health impact, mental health impact, significant and widespread economic shocks and job instability, which means when the pandemic is over, the economic repercussions are not going to be over for a number of years. So longer term or delayed educational plans, longer term job instability, and of course the traumatic impact on things like basic needs, eviction, putting food on the table. These are really different in the case of COVID because of how quickly it sprung out of nowhere and how long of a tail the consequences of COVID will be. So today's phenomenal keynote speaker, Sonia Renee Taylor, has this very good quote here. Systems do not maintain themselves, right? We talked about this. These things are changeable. Inequities are changeable. You can improve them, but what can you do? Well, you can change the status quo, y'all. You can advocate, lobby, write, study, research, publish, do whatever you can do. Get a job in public service and actually serve the public, the common good. And of course, you can vote, encourage others to vote, and don't stop. You ever heard of the squeaky wheel principle, right? If you don't know what that is, that's when you're pulling along a wagon and one of your wheels is squeaking. Which one gets the grease? The squeaky wheel gets the grease. So don't be afraid to be squeaky. And as John Lewis, the late great John Lewis said, go out there and cause some good trouble. I'm going to end there. Happy to take any questions. If Claire is going to be generous with us in terms of time, I don't know if we've got to end, but I am all open for discussion and questions. Thanks very much.
Yeah, if anyone has any questions, if they're quick, we have a few minutes, so you can ask them in the chat. And I just want to thank Dr. Nazmi for being here today and giving us such a great presentation, and for all of you for coming here and just caring about learning about these things. And right now I'm going to be sharing a link in the chat. And this is a link for you to provide feedback on the workshop, and also for each workshop you attend and fill out this survey, you get one entry into our sort of prize thing, and if you win, then you'll get something at the end. And I'll be hanging around too if anyone has any questions.
Claire, do we have time to take a couple of questions from the audience if there are any? A couple
Yes.
minutes?
Yeah, we can go. They're fast. Yeah,
Beautiful,
if anyone
beautiful.
wants to just turn their mic on and ask.
I'm going to stop sharing.
I have a question. I'm an Indigenous, I work with ICOP, which is a nonprofit organization that works with Indigenous communities. And we have seen the disparities, everything that you spoke about, it's exactly how it is out there. And I wanted to prepare a little bit on how I can help my community in their language, get all this information and understand kind of like, you know, the bigger picture of it and how it would affect them. And just, you know, with everything, COVID has definitely shown the disparities even more and widened them even more. Is there any class that you recommend that we can take, or any type of like research that we can get into? I'm looking for another 4 units for next quarter, and I would really appreciate your recommendation.
Yeah, are you a Cal Poly student?
Yes.
Oh, well, you know what? Your timing is phenomenal. So I normally teach a class spring quarter called Population Health and Epidemiology. Now, I have to say in my role working with COVID, I don't have time to teach it. That's the bad news. The good news is somebody else is teaching it for me, who is a very capable person. And it is a graduate level course, but we do accept advanced undergraduates in that course. And it's called FSN 516 in the Department of Food Science and Nutrition. And it is all the stuff that I talked about. It's that. It's a little bit broader. Obviously, it's a quarter long, but I would suggest you look into it. And if you want to reach out and talk to me about it, or see if we can, I don't know if you're an undergrad, graduate student, but I'll contact the professor, contact me, and I can hook you up in terms of how to take that class.
Thank you. I'm an undergrad. I'm graduating this spring, hopefully.
Oh, great. So it's perfect for you, actually.
Does anyone else have any questions?
I see maybe we'll just take this as a last one.
Oh, here. Yeah, sorry, I can read that.
What are some solutions you think are needed for getting vaccines to the highest impact areas? So we saw in the slides that exactly the opposite is happening. And this is a, you know, and I hate to say it, but it is a failure in planning. It is a failure in leadership at the federal level, at the state level. The counties and local jurisdictions don't have too much control over vaccines allocations or vaccine. They do vaccine distribution. So at the local level, yes, you can advocate and you can lobby for those who are in underserved groups. But it is really up to the state to say what is allowed, what is not allowed, especially in a state like California that has 10% of the national population and is so big and is so diverse. It is a very complicated prospect. But what I have to say, usually I'm a pessimist, but in terms of vaccines, California has done a pretty decent job, and we are ramping up all of those large, I think Dodger Stadium, right? Another stadium in Northern California. These large vaccination sites are opening. Has that eliminated disparities? No, it will not eliminate disparities. But what we can advocate for is opening sites like that, and even clinics and even mobile clinics that go out to people, because we know even just the act of getting to a place exacerbates disparities. Folks don't have access to transport. Folks don't have access to cars. They live further away. They live in rural areas, etc. So working with and putting a lot of pressure on, I hate to say this, but public health at the end of the day ends up with this squeaky wheel principle. The groups, the advocates, the lobbyists that make the most noise and put the most pressure on politicians, and this is why I say public health is inherently political, are going to get the most attention. Okay, so I would just advocate for squeaking as loud as you possibly can.
All right, unfortunately, we're gonna have to end the meeting now, but thank you so much to everyone. And just a reminder that after the conference is over, there will be a conference feedback form that will be emailed to everyone. So thank you everyone for being here.
Thanks all. Bye. Thanks, Claire.